Hello, good morning and welcome for this session. This is a session on DSEK, and DSEK still remains, even though the further latest endothelial keratoplasties and other procedures have come into wake, but still DSEK is a main jumping board from which we can move on to the other things, and also it has its own place in the endothelial, in addressing the endothelial diseases. So we'll start this session with a guest lecture from Dr. Dsaek from Sri Lanka. He is a board certified consultant in Sri Lankan National Eye Hospital, Colombo, and his area of interest is cornea and external eye diseases. And he contributed in many of the national conferences in Sri Lanka, as well as Asia Pacific Conference and also DAS Joint Conference, and he was an invited faculty in many Caracon also. Now, and his areas of interest are lamellar corneal surgeries on ocular surface reconstruction, and also cataract and lamellar and keratoconus. I invite Dr. Ratnaike to come and give his keynote address.
Thank you very much for the introduction, and good morning, everybody. And first of all, I like to thanks the organizing committee of the AIOC2020 for inviting me to talk this on topic.
Yes.
Manual dissecting deep anterior-lamellar keratoplasty for extreme keratoconus.
Yes.
Anwar et al. Big bubble deep anterior-lamellar keratoplasty has become the treatment of choice for advanced keratoconus, and it has modified for the scars and the other stromal pathologies spared in descendant membrane. The likelihood of achieving big bubble is not 100%, even in the hands of very experienced surgeons. The situation is more challenging when the patient is having a deep scar at or very close to the DM. Having a backup technique can increase the success rate of DSEK. We herein describe an effective method to aid in corneal stromal dissection for DSEK in deep-seated corneal scar. One of my patients, a 28-year-old male, presented with reduced vision in both eye over 1 year, and best spectacle corrected visual acuity 636 in both eyes. His best contact lens corrected vision in right eye with a ROS scale is 612, but vision is not even improved with semi-square contact lens in the right eye, left eye. So he's not basically happy with the contact lens, as is intolerant the left eye more than right. This is an axial curvature map of the patient, shown very advanced keratoconus. You may notice steep K over 75 in both eyes, particularly in the left eye, both K1, K2 is over 75. The anti-segment OCT gives valuable information on preoperative decision process. If you see very carefully, you may see a very deep-seated scar very close to the DM of this patient. OCT pachymetry of the left eye also reveals 293 micromons, is very thin cornea. So what would be the best treatment options for this patient? Contact lens, yes, but patient is basically unhappy. So best possible option would be the cornea transplantation surgery. When you plan a DSEK for this type of patient with extreme keratoconus, it's wise to keep a backup optical grade cornea. So my method, the stromal spiral method, the basic steps: debulking of the trapine host cornea, creation of a stromal pocket to introduce the scissor. A pair of blunt corneal scissors is used to create a lamellar plane. Blunt dissection of the stroma using the universal scissor in a clockwise or anti-clockwise fashion with your preference. The dissection plane then spirals down like a minute hand of a clock. When reaching the deep stroma, you may use the blunt round body or stroma dissector in addition to the corneal scissor. In this fashion, with the 2-3 circular dissections, you may be able to reach the descendant membrane. These are my results. After 3 months, the best spectacle corrected visual acuity improved 612 in the left eye, and the image of a slit lamp shows very clear center cornea. Our results in the sample of 18 cases of planned manual dissection DALK, basement membrane, the bare basement membrane, decimate membrane achieved in 11 cases. Pre-decimate dissection has to perform in 4 cases. Microperforation occurred in 2 cases in which one was uneventful postoperatively. In the other, double chamber resolved in 5 weeks. One case has to convert into PK. Mean preoperative best spatter corrected was 636, improved significantly to 612, and you may see the central keratometry also improved significantly in that particular patient. This is the video, a short video of my case. Some standard markings before proceed. I use a vacuum trephine up to 2/3 of the depth of the minimal corneal thickness. Then debulk of cornea using a crescent knife. This creation of the stromal pocket is very important. A pair of blunt universal corneal scissors is then used with the closed tips and then very slowly spread. And you do it in a clockwise or counterclockwise fashion. And each time you go deep when you reach each spiral. This is round body dissector. As you go deep, I think it has a definite place because spreading blades close to DM is not very comfortable or little bit risky. And better do a very vertical cut close to the trephine margin, then you can nicely see it your donor cornea. With the 2-3 circular dissection, you will be able to reach and better to do a paracentis, and when the eyes keep very softer at this stage, it's very easy to separate the lamella, the pre-decimate lamella, and this is how I reach the DM. My secret is I do a very small paracentesis and use a round body dissector before the blade. So you have to keep you debulk, then your visibility is better, and you can have a better grip with a 0.1 to the fine colibri. And this part is very important. If you notice a scar very tightly attached to the DM, better to cut rather than remove. Now you see the reach, and rest of the thing is your basic DALK suturing. Blunt dissection with scissors has been long established as a valuable surgical technique. We use universal corneal scissor and blunt round body dissector to separate and remove lamella in the current era of bib bubble technique. This technique provides corneal surgeons with an alternative method of bearing decimate membrane or achieving a pre-decimate membrane with minimal residual stroma when attempted bib bubble is a risk of perforation. Thank you very much.
Thank you, doctor. Thank you for that very elegant, beautiful video. And as you said, like in advanced keratoconus and where you see the scars, it's better not to attempt the big bubble. You may end up in problem, and manual dissection is a very, very good method for that. And also we can try hydrodissection. As you go deeper, you can try hydrodissection also, which will loosen the lamellae very well. Thank you very much.
Thank you.
So,
No, you just
yeah, I will start with the session now. I call Dr. Dsaek on pearls in case selection and preparation of DSEK cases.
Good morning, everyone, and thank you, madam, for inviting me into this course. So I'll be talking about the indications, case selection, and pre-op evaluation in case of DSEK. So very simply put, DSEK indications is any case of endothelial dysfunction. Now to elaborate, the most common indication that one would come across is a pseudophakic corneal edema or a bullous keratopathy with IOL in the bag or in the sulcus. DSEK is also possible in PBK where an ACIOL is in place, but things to be taken care of are noticing how the chamber is deep and how much the IOL is mobile. The challenge here is there might be more endothelial cell loss, and sometimes you might have to do an IOL exchange with an SFIOL or a retrofixated claw lens. But if with a deep chamber and a well-centered ACIOL, the results of DSEK are good. But sometimes in cases like this, where there is gross corneal edema, poor visibility, and a decentered IOL, it's not an ideal case for beginners. But advanced surgeons can go for an IOL exchange, put a scleral fixated IOL, and then do a DSEK, maybe in the same sitting or as a staged procedure. But all cases of PBK are not amenable to DSEK. Cases like this, cataract surgery operated 5 months back, but the central corneal thickness is more than 1500 microns and the visibility is nil. So here you will have to go for a penetrating keratoplasty. FECD we see more in the eastern part of the country. So FECD, the decision making here is whether to do only DSEK and a phaco or go for a combined surgery. So that would depend on the grade of the FECD and also the age of the patient and the cataract changes. If you're doing a staged phaco and then a DSEK later on, it's better to give a guarded prognosis, mention that they might need a transplant later on, and when you're putting an IOL in, keep the target at -1 to -1.5 myopia. But one should remember that all causes of corneal edema is not due to endothelial failure, because something like this where you have an high drops in case of keratoconus, here a DSEK is not the answer. Post PK failed graft, so as your practice grows, this will happen, your PKs will fail, and DSEK is a very good option for treating these failed grafts. Important factors to note here is the amount of astigmatism, how much the stromal scarring is there, and the extent of pass and how many clock hours are involved, and also the lens status. This, in the Indian subcontinent, again, is a very important. We do a lot of therapeutic keratoplasties, and a visual rehabilitation option, DSEK, again, is a very good option. So you can have you can have a therapeutic keratoplasty which will eventually fail, and later on you can combine it with a cataract and a DSEK for good visual rehabilitation in this mostly farming population. In case of where previous glaucoma surgery has been done, DSEK is possible, but the challenge here is one, air tamponade, because air tends to leak out to the subconjunctival space, and in presence of tube, the sizing is very important, and while inserting the lenticule, there might be some excess loss due to tube touch with the lenticule. Other relatively uncommon indications are CHED, PPCD, aphakic bullous keratopathy, ICE syndrome, and post-herpetic endotheliitis. For beginners, few cases that should not be attempted initially are aphakia with lot of vitreous in the anterior chamber, poor visibility with excessive pass in case of an ICE syndrome, or where the ACIOL is decentered, or where there is a limited iris support. And sometimes even for advanced surgeons, DSEK is not a candidate, even though the underlying pathology is an endothelial failure. Something like a severe Fuchs with vascularization, aphakia with large dilated pupil and AC full of vitreous, excessive stromal scarring, or where the visibility is absolutely poor. So to summarize, the ideal case for a beginner would be a PBK case where the IOL is stable, early Fuchs with cataract for a good triple procedure. Make sure you have good anterior chamber visibility and a good iris support. There should not be any large PI or complete iridectomies. In case of a triple procedure, IOL preferably in the bag, and IOP should be within normal limits. So this is the data from the Shai Hospital about 3 years back. So the highlight here is the FECD makes up quite a lot of our cases, about 25%. PBK remains the main indication. Regraft again is almost 7%, and the others have very few indications. Now for workup and pre-op evaluation, for a beginner surgeon, it is always nice to maintain an Excel sheet so that you can track your data and later on you can present the data into different forums. So this is just a rough guideline of how an Excel sheet might look like. I'll talk about individually. So you've mentioned the diagnosis, whether it's a PBK, Fuchs, post-PK. BCVA, for beginners, better to start with 6/18 or poorer vision, because then only the patient will be able to appreciate the improvement in vision. However, for an advanced surgeon, they might even attempt at 6/9 or 6/12 vision. BCVA of the other eye is also important for giving prognosis to the patient. And diagnosis of the other eye is also important to look for any missed FECD or normal in case of eye syndrome. Lens status is important for your surgical planning. Look whether the lens is PCIOL, phakic or aphakic. If aphakic, look at the other eye status also, whether you would need a secondary IOL implantation. Prior corneal surgery, whether it's a PK therapeutic or DSEK, again, little bit surgical planning based around your graft sizing should be within the graft host junction of the previous penetrating keratoplasty. For prior glaucoma surgery, you should be prepared for shallow AC and poor air tamponade, and also these are patients who are likely to need more postoperatively more anti-glaucoma medications. And prior intraocular surgery, like even vitreoretinal surgery also, it is very difficult to get a good airfill. In pseudophakic eyes, the IOL type and the IOL material is also very important. ACIOL, iris fixated, both are challenging for achieving a good air tamponade. Sometimes you might need to do an IOL exchange. If PCIOL in the bag is good, in the sulcus or unstable, again your AC becomes very unstable. A hydrophilic material, when you're giving airfill, might opacify over time, so that's one thing to be given as a warning to the patient. Pupil, look at the shape, size and position and the pupillary dilatation, which would also give you a hint of any presence of vitreous in an otherwise hazy cornea. YAG capsulotomy, two things can happen. One, vitreous might leak into the anterior chamber, and two, you might not be able to get a good air tamponade. And vitreous in AC requires a very good vitrectomy before putting your graft inside. The investigations to be done, if the edema is not much, you can take a look with a 90D or an indirect, but otherwise a USB B scan is very important to look at specifically any retinal pathology and how the disc looks like. Axial length for biometry, because the surface is so poor, you might not be able to get good K readings. So you might have to take from the other eye also. Anterior segment photography for documentation. ASOCT is probably the most important investigation here. Look at subepithelial scarring, look at stromal scarring. In post-PK cases, look at the graft host junction, because that would determine how the posterior edge of the graft host looks like, and that would determine your DSEK lenticule sizing, and also measure the pachymetry. And during surgery, you need pre-op clearance from an anesthetist. In case you're doing it in a phakic cornea, whether to do a cataract surgery or a combined surgery, in our practice, if the patient is above 40 years, we plan a combined surgery. But for a younger patient, we do a DSEK, and later on we say that he or she might require a cataract surgery. But the cataract formation in these patients after DSEK is actually faster because of surgical manipulation, the postoperative steroid, and also air-induced cataract formation. If you're operating situations like eye syndrome, it is better to do a cataract surgery anyway, because that gives more anterior chamber space and to some extent helps in the IOP control. Cataract surgery after DSEK is not difficult, but extra care should be taken to prevent as much as endothelial cell loss as possible, like soft shell technique and using BSS+. Now, if you are doing a triple procedure, if the chamber is good and the visibility is adequate, you can go for a phaco, but for advanced cases like a post-therapeutic failed graft, sometimes we need to use manual SICS technique. IOL of choice is hydrophobic acrylic, preferably a white lens, yellow lens only if the other eye has a yellow lens, multifocal not to be attempted, toric may be considered if the astigmatism is very large, IOL power, your target should be -1 to -1.5 to compensate for the lenticule and change in the corneal edema. Specular microscopy is also very important. If the edema is not too much, you can do the specular microscopy in the same eye to show the disease process to the patient. And in case of, and also to look at the other eye, So you might have some undiagnosed Fuchs, give confidence to the patient, tell them that only this one eye is affected like in eye syndrome and the other eye is absolutely normal. And also sometimes to guard our cataract colleagues. Thank you.
Our next speaker is Dr. Revathi. She will be speaking on manual versus automated donor dissection.
Thank you. And in this talk, we'll see how to prepare the donor tissue. So go for a cornea which is having not only good endothelial count, which has a very good endothelial cell morphology and good picture and also fresh tissue. And then you let us see how to prepare the tissue. So the equipments we need, any kind of artificial anterior chamber, preferably a lightweight one, and though they are disposable, many times we used to reuse. And we can, this kind of lenses, like this kind of anterior chambers, we can hold in hand and tilt as we want, so that we can keep the line of plane of dissection always perpendicular. That way it will be easy, and we can use anything like any a gauged blade should be there, and also the dissectors can be permanent ones or disposable ones. Even the disposable ones we can use several times. And coming to the donor tissue preparation, while mounting the tissue on the artificial anterior chamber, it should be devoid of all conjunctiva and tenons, and also it should have optimal amount of scleral skirt, so that it will fix snugly on the anterior chamber, and so that it should be maintained to like while we are dissecting. It should not get deflated, or the pressure should not come down, which can lead on to thicker grafts. And also it's better to check even after mounting any leak, either from the chamber itself or from the after you mounted it, because if the, as I said, the scleral skirt is not clear and it is less, and then there may be a leak also. So going for the actual dissection, after mounting it and centered it properly, we have to mark and also check the pressure. It should not be very tight, too tight, or it should be slightly dimpling. The pressure should be in that way, as you see here. Then we can start from the limbus. We can make with a gauged blade around 2/3 or 3/4 dissection cut, and then we can start with this small black shadow in front of your the dissector will give you the idea about the thickness of the remaining stroma, and we can titrate it accordingly, and then we can go and complete the dissection limbus to limbus throughout. And we can use either the proper ones, or we can use the disposable ones, which are more handy and elegant to use. And we can also do the double layer thing also, so that we can go for even ultra thin dissect buttons, even with the manual method. After dissecting the first layer, we can reassess, and again we can do the same pocket-like dissection, so that to get a even uniform smooth surface, and we can titrate the residual stromal thickness, which can be really ultra thin, like as you can get in automated one, and even with the manual method it is quite possible. And here you can see, after cutting and taking the tissue, it will be too thin. It will almost behave like a DMEK button when inserting. It will curl towards the endothelial side. And that disadvantage in the manual method is you can get the rough surface, so that there may be interface opacities, and also you can't titrate the thickness of the button always. But if you go for the like automated one, you need an expensive instrument, of course, a microkeratome, which function almost as the LASIK microkeratome, but here we are making a thicker anterior flap. So through and through anterior flap we make different head size we can choose according to the cornea's thickness, and we can use this, so that you can get a uniform and smooth surface. That is a big advantage. Other than that, not much of an advantage with this automated one. At least I don't find any great advantage. But one thing, technically it is very easy, so that even your technician can be trained in the eye bank. If you plan for pre-cut tissue distribution, this is an ideal method. And but not that you won't get any complication in this as a mechanical instrument. Here also mechanical failure can come, and if especially if your scleral skirt or rim is not properly cut, again as you see it lifted up, and with that again it was attempted, and you see a incomplete cut or a very superficial cut. One more attempt also was made, but still it was incomplete because the chamber pressure was not maintained. Then you have to convert into a manual this thing. This can be easily done. Even here sometimes to get a thinner flap, I used to do this manual thing. And that's why the manual dissection method we should learn as manual SECS. Any times it may be helpful for you. And that is the thing, like the dissection of donor tissue we can do in these two ways. And about the insertion, the techniques and the other problems, Dr. Revathi will take over now.
And now Dr. Revathi, she will be speaking on recipient preparation and donor insertion.
So we can have more time for discussion.
Yeah, yes.
Yeah. Thank you, sir. And thank you, Dr. Revathi, for including me in this course. I have no financial interest in the mention of any products, procedures during the course of this talk. So I'll take this forward to the next step, and will be primarily dealing on recipient preparation and donor insertion, tailoring it particularly to the needs of beginners in, as this course is rightly directing it to. When you look at donor preparation, tissue preparation, the main steps which you will need to pay attention to would be how you would really handle the tissues. This is when you're looking at donor tissue. So donor tissue mounting, scleral rim, looking at the limbal conjunctiva, looking at the microkeratome suction. I primarily use the microkeratome most of the time, so I do not do manual dissection for preparing. And that was a very nice and easy technique, which is less costly also, which Dr. Revathi showed. And then finally is the trephination. So these will be the steps when you're looking at donor tissue preparation. So we'll move on to the recipient tissue preparation. And when you look at recipient tissue preparation or the host bed preparation, what you will need to pay attention to is the decision on where you want to make your primary incision. That will be point number one. Then you will need to look at the amount of clarity of the cornea which you have when you want to decide on what kind of procedure, which I think Soham rightly pointed out very nicely in his talk. Then point number three is the pupil management in these cases. Depending upon the case, whether it is phakic or it is pseudophakic or aphakic, you would like to have your pupil dilated, you would have it to be constricted, so you will think about pupil management in these cases. A word of caution for beginners also, try to examine your case very thoroughly, and do try to have a suspicion of floppy irises in such cases, here, and patients where you might have increased positivitreous pressures, because these cases as beginners will not be very easy to handle if you will land in problems, and your unfolding and positioning might not be very easy when you're handling a case of floppy iris here. The next step is the Descemet's membrane scoring here, where you would want to remove the Descemet's membrane from the host cornea before you would place on the DSEK lenticule and attach it onto the host cornea here. The lenticule management comes first, and the last is the bubble management. So these are the sequence of steps, and though it might look like a simple surgery, it does take you through a particular learning curve before you would probably master all these in difficult scenarios. So I think Revathi has already covered most of these here, and one particular word of caution when I do prepare my tissue here is I'd always like you to have the bed of stromal tissue here. And when you have the anterior stromal tissue here, and when you load it on, several surgeons also prefer to have the anterior stromal bed kept on your Busen's glide when you're loading here before you just take out the lenticule. That helps to prevent or keep your stroma with as minimal distortions and minimal damage to the stromal tissue, and you just pull in the right lenticule into the cornea here. So as you particularly see in this eye here, so my decision is lying primarily here. I do have my AC maintainer which is positioned in this direction. If you do it the other way around, when you're inserting, your AC maintainer can come off. So that's one word of caution. As you noted earlier, I always make my second incision a little more oblique and do a dry run of the DSEK forceps, or we primarily use the ILM forceps in our cases here, and bend it across. So I do a dry run to see that it is going in without causing pupil distortions, iris, floppy irises, or iris coming out through your main wound before you really pull it in. And as soon as you pull it in, you put in a bubble here and secure it fine. Position your lenticule well, and then do a complete air fill, and we wait roughly about 6 to 8 minutes and before we lessen or decrease the bubble and fill in the residual thing. If you feel it's a secondary glaucoma patient, you could still use a PI in most of your patients here, which would help to relieve the postoperative pressures in such cases here. And you also will have to pay attention to propping your patient, or positioning your patient in a supine posture for 24 hours following surgery. And also remember to tell all your attendants who are shifting the patient to shift the patient in a supine posture. The patient is also counseled that they will not adopt a side posture or a probe posture for 24 hours other than the time they're going to spend in the toilet. So that's also going to be imperative in the way you will deal with these patients. When you're looking at corneas which are slightly hazy, and if you do have the advantage of an intraoperative OCT, that would also make your surgery much easier. Yeah. So we'll just move on to the various other techniques of insertion in our cases here, and I have collected a couple of videos from some of my seniors here. This is Dr. Vasak's video here, and when you're not using a Busenclide and it's a taco fold here, so that's how you go about your taco fold. The rest of the steps are primarily the same as you would do for several other, as you do for any other DSEK. So here is your taco fold here, and always remember your forceps should not be tight. Use the indicated forceps for your taco fold here, and this is a simple insertion which would just go in straight on and put in here. Yet another method of inserting your lenticules, that layer it on, fold it again. Always use the anterior stromal lenticule as a bed onto which you're going to mount here. You can, if as a beginner you're not confident in trying to identify or worried it's going to be upside down, marking always helps you to really place it in the right way. So that's how you go about. This is really a simple way of inserting. You do not need sophisticated instruments for these, but always remember, if you have a floppy iris, these things can be a little dicey. So that's something which you will always have to keep in the back of your mind when you're taking on such cases here. So we'll just move on to the next insertion, next scenario here, when you're doing DSEKs for a little more advanced cases, as you would do for CHED. So as you can find here, the CHED corneas are not as clear as you would have in a bullous keratopathy, a pseudophakic bullous keratopathy, pseudophakic corneal edemas here. So the haze might be very deceptive when you look at it. The slit lamp, remember your slit lamp optics is much better than most of your operative microscope optics here, and you might find the cornea to be more hazy when you see it on the table here. So that's a word of caution for beginners until you really get used to how you're handling your equipments in these in the anterior chamber of these corneas. So these are scenarios where you'll have to warn yourself beforehand. The other steps are pretty much the same here. These are small eyes, pediatric eyes, and done under general anesthesia, so do not leave them sutureless. So we do tend to do a lot of sutureless DSEKs when we are doing adult patients, but for these pediatric patients, a word of caution is do not do sutureless DSEKs, even if you find your chamber is watertight and airtight at the end. Always remember to seal these incisions, and an intraoperative OCT is something which is indicated in such scenarios where you'll be able to position. And what is also more important, when it's as hazy, you probably will not be able to find out if you've scored off the descemetes completely in certain scenarios. So that's one scenario where the intraoperative OCT helps you. And if it's a very shallow chamber and your iris is not behaving well, you would be able to look at these parameters with more detail if you have an intraoperative OCT here. Again, one other, I think Revathi already showed this here, when you're looking at post-PK scenarios, when you're doing it for failed penetrating keratoplasty grafts here, you probably can go ahead without doing the descemate scoring in these patients here. So you could just go in and directly insert here. Remember, when you're doing taco folds and you're doing direct needle insertions, it always helps to ensure that the surrounding area here is going to be absolutely free of any infection or any, because this is one area area where you could probably spread in an incision, and here you would always like to have a larger incision as compared when you do a Busin glide here. So that's an aspect which you will always keep in the back of your mind, and the astigmatism which could arise in these particular scenarios here. One other insertion method is the suture pull-through method here. You could use it again. It's a very easy method of inserting here. You could use it when you're using in aphakic cases or large pupils. You have a scare that your graft is going to fall behind here. You can secure it at the end of your surgery, and you would be able to remove and you can place a suture on and remove the suture after in the postoperative period once you are really sure about the graft adhesion. So that is a suture pull through. It's a simple method, just like a taco fold. Use your anterior stromal lenticule as the carrier, and on which you would fold in and use a 90 prolin here. But remember, if you're using this on ultra thin grafts, then there's a tendency that you would tear through the graft. So do be careful here. It's a very simple. You don't need sophisticated instrumentations on this. You could probably combine it also along placing it along an AC glide and then putting this in. You could also use it when you're using in cases where the ACIOLs have been placed and the IOL is stable enough and you do not want to do an IOL exchange in these scenarios. So that's one other method of insertion of your cases. There's a TAN glide as well. I'll just quickly sort of run forward through this video here. And because of the cost which you do incur on your TANS glide, we do not use it so much as you would use as frequently, but this is another easy method of insertion and does help you to place your grafts well, especially in cases we have floppy irises and other difficult scenarios which Soham pointed out rightly. So these are the particular ones in which you would not want to, or you would be wary as a beginner when you're doing endothelial keratoplasties here. I'll stop here and thank you for your patient hearing.
Thank you, Dr. Revathi, especially all those small points, very important points you gave. And now I call upon Dr. Manoranjan Das for the management of intraoperative and postoperative complications.
Good morning, one and all. Thank you so much, Madam, for giving me this opportunity. And I would like to start with the major intraoperative and postoperative complication. Surgery which is done always looks good with the competent hands and looks also very easy with competent hands. It's not that surgery is easy. So just a meticulous workup has to be done, starting with the case selection and the type of procedure you want to do it. So mostly the complications are divided into intraoperative and postoperative complications. Intraoperative will cover during the donor preparation, recipient preparation, donor lenticule problems, lens or IOL related problems, or AR management. Similarly, postoperatively, graft complications with the dislocations, graft failure primary, graft rejection, graft secondary graft failure, AR related complications having secondary glaucoma, interface debris and problems, infections which is rare, and secondary glaucoma. So we start with intraoperative complication. We can have a placement of corneoscleral rim in the artificial chamber that can be eccentrically placed or can be inadequate size in which it pops up. The scleral rim should be ideally 3 mm or around, so that it helps you to stabilize the button and the artificial chamber, or if there is partial loss during the creation of the pressure, that also can suddenly collapse the button, or if it is too tight, then you can get a thin graft or a perforation during the pass. So there are also few problems with the automated microkeratomes, like you can get a irregular graft due to the uncontrolled or the improper microkeratome pass. So it can be thick graft, thin graft, incomplete graft, partial cut, or poor handling of the tissue. So this is the actual picture which shows the thinnest graft here. This is irregular graft, and also you can see the thick and thin, and this is very thick graft. And this is the AIOC picture which we usually take if you don't get the adequate thickness. And again, coming to the patient. So patient preparation is very important. First and foremost, you should have a very nice block, because to avoid the positive pressure. Wound related proper site of incision or the tunnel creation is very important. It should not be too anterior. Side port, in most of the cases will have vascularized cornea and limbus all around, so it should be very nicely placed so that the intra bleeding should not be there, and tight tightness of the tunnel. If you make the tunnel, please measure for the beginners, you measure the size. It should be exact or little bit loose enough so that you get through the tunnel very clearly. Iris related problems are always due to the excessive positive pressure or selecting cases which are really too tough for the beginners. So intraoperative bleeding is always chance is there. So you please place your tunnel incision or the side incision in a proper way so that you avoid the intraoperative bleeding, sipping of the blood from the tunnel or the side port. These are the remnants. You can see the remnants of the Descemet's remnants. When you choose a bad case or a very thick posterior stromal scarring, it is really difficult to remove the remnants of Descemet's membrane. Here we could not remove it, so there is a bend in the superior part of the cornea. The infolding of the lenticule is seen. So Descemet's lenticular problems, you can have a upside down. You can see the upside down, so smooth surface which endothelium is stuck, and this is the aphakic which I was doing, and it just fell down. So sometimes it can go inside. So and this is another tissue handling. If your tissue handling is repeatedly collapsed and or it has come out again and again, you are putting, so you can have a primary failure almost like picture in the very first day itself. So it should be very carefully monitored. All is not every time is bad about the DSEK. So the very nice study which I have done with depends on the insertion. So once you prepare the button, so that should be properly inserted. So as Vanati already told, the glide taco fold, this is a comparison done by Jodhve Mehta. So they have just found out that taco fold is almost not as good as glide insertion. So because of this type of good studies, we have shifted from almost taco fold to the various type of glide insertions. And next, is it so bad? You can see another study from the same center, we got it, where they have showed that the Busin glide and endoglide is always better again, but the cost is the factor. So difficulty coming next to the air part of management. So inability to maintain the complete airfill can be due to proper improper case selection. So it can be intraoperative complications like severe positive pressure and PCR or vitrectomy, which you can encounter during the surgery or pre-op. You have, when you have selected a hazy cornea stromal, you do not know, you suddenly discover the vitreous there in the AC. Or it can be due to the pre-op morbidity. So if you go ahead with your experience, you can do all these relatively difficult or relatively contraindicated patients, but anyhow you can also get through the surgery very well with experience. So lens problem is mostly when you attempt to do a pseudophakic cases referred to you, you hardly see whether it is ACIOL or PCIOL. Please, you have to look for the proper centration of the ACIOL. I personally feel ACIOL doing surgery is challenging, and again, if you do a primary surgery, please try to overcorrect the lens with a hydrophobic lens. That is the take home from that slide. So pseudophakic, again, mostly we choose hydrophobic lens, and if you choose this hydrophilic lens, then you will have this hydroxyapatite deposits on the lens. So next, coming to the post-operative complications. This is all as you grow mature with your surgery, you try to do something little bit challenging cases, so you can land up in post-PKP case which I have shown it. So next day the lenticule was in the AC. So please take care of this, and the main causes of this dislocation will be the poor endothelium function of the tissue, or the viscoelastics at the interface, or it can be inadequate airfill, or you are having a interface fluid or eye rubbing by the patient. So reposition can be done with the next immediate post-op. So this is a cleft again, showing this cleft where it is, and there is a edema, focal edema. You can see this is a edema here down, and there is a cleft, and there is an oral cleft. The different type of degrees of cleft I can show you. These are the different type of clefts you get in the different type of thickness, irregularities. These are all like learning curves, and this is actually almost is a common drawback of DSEK. So please be very vigilant for the amount of this cleft you have got, and depending on this, you have to take a call for resurgery immediately. So primary failure mostly is iatrogenic, and you have to take a call only after 2 months. Okay. Then the graft rejection is very rare, but you can see the line here, but it is always, even though it is rare, it is much safer than the PK surgeries. So coming to this study, this is a very nice report in 2009, which they have all told about the goodness of the DSEK and why this DSEK is more prevalent over the PK. And this is another study which shows the survival of the endothelial cells, and the main thing is that the increased failure, you have to think that increased rate of secondary failure with the eyes with previous glaucoma surgery, and after 6 months the endothelial cell loss stabilizes in the DSEK patients. So post-op hair complications can be pupillary block or can be Ujed syndrome. I have shown a pupillary block, hair is blocked there. So incidentally in all cases I do a inferior PI, and interface problem, same thing, Descemet's membrane residual, and these pigments are there to show. And infection, although is very rare, it's almost like fungal infection, and you can see the surface dendrite. And this is a peripheral melt with secondary infection, and this also, sometimes we, after dissection, taking a bad case, we have a 360-degree bullous keratopathy, and if it is not taken care of, then it will come with the presentation of secondary infection at the. So iatrogenic is very, glaucoma is also has to be given importance. Mostly it is by steroid responder or secondary closure when you take up difficult cases, and chronic inflammation. So how do you know to prevent? Please select cases with no stromal scarring to begin with. Deep AC should be the criteria. Round pupil, no pass, no vitreous in AC. Adequate tunnel size, at least it should be 5.5 millimeter. Donor tissue selection be now there is no dearth in getting the donor tissue. To start with, you should at least check 2,700 or 3,000 cells type of tissue you select. Surgeon choice is always important type of insertion. Whichever you are comfortable, please do it on your hand. It will be good. And the take-home message from this is that the 60% of the endothelial keratoplasty is now being performed. It is a growing trend in India. And to proper case selection to start with, so that it doesn't frustrate you. The relative contraindications should be only managed by the senior surgeons. Insertion technique should be chosen only with the surgeon's comfort, and good selection of the tissue is bare need. Thank you. Thank you for the kind attention.
Thank you. Now Dr. Dsaek will talk about DSEK in challenging situations and why he chose DSEK to do DSEK in these cases.
Thank you, Dr. Revathi, for including me in this course. And good morning, everybody. So my talk is on why did I choose DSEK here, some of the case scenario, and we'll discuss after this my talk. So you know that this is the DMEK, the era of DMEK, and I do a lot of DMEK, and the main important factor is good visibility, and there are other factors also. So if you see this for last 3.5 years, I have done more than 800 DMEK. My ratio is now last year 275 DMEK, and DSEK may be around 40. So what are those cases where I cannot do DMEK? So the first indication is extremely poor visibility, some cases of post-Trab or post-tube, some post-PK failed graft, similarly some post-failed DSEK graft, some CHD patient, aphakia with very large pupil or very large optical iridectomy, some of the post-AS cases when the DSEK tissue is damaged, and some failed DMEK eyes. And there are other indications, those are not related to actually the visibility or other factor, extreme of ages, less than 3 and more than 90 years of age. Head positioning where there is a huge problem, patient is very fragile or weak, you cannot take that patient for a second time. for rebubble. So first one is DSEK in presence of poor visibility. This is my very old video, maybe 2008. And you see that this patient is bilateral FECD. The other eye has already had infection and has a scar. And so what is the choice? So that time, PK and ECC was the choice that time. But I did manage to do, I call it the double manual combined technique. And this video got the best video award in ESCRS. And I did SICS, a little bit blind SICS. Then I removed the cortex, whatever I could see, and then some of the epinucleus, and then put PMMA lens. And next, I put a DSEK lenticule here. And I used actually, that time knowledge was less. I used actually the reverse 26 gauge needle to cut the DM for desmatorexis and remove it. And this lenticule insertion is like a teco insertion, and I put it there. And you know that this patient was like this after, say, 4 to 6 weeks, and 12 weeks post-op, and patient enjoying 6-12 vision. This patient recently died, and he maintained very good vision. He didn't go for the other eye operation, was doing fine. So these are some of the cases where, but this type of cases now I can do DMEK with IOL. And this patient, you see that tecofold is not a bad technique. If you stick to a same technique, I did at least 1400 teco technique, and this patient over 12 years, you see the cell count, 1528. So it can be replicated over and over again. This is another patient. You see that referred for PCIOL from a long distance, and he has a positive history of HSV endothelitis for repeated attack, 4 records available with it. I thought other eye ICIOL, I thought I'll be doing PCIOL. He's a teacher from a long distance, probably one go. And then there was no active inflammation. And I took the patient on proper protocol, oral prednisolone, oral acyclovir, and explained prognosis that something might happen. And then I started this patient on like PCIOL, but on table I thought if I could do like FECO in this case, can I go for DSEK? So that was the only part of visibility. And I did FECO, but the tunnel making, external tunnel was like 5.5, but internal incision was only 2.8. I did FECO, very difficult, but could manage it. I believe most of the corneal DSEK and DMEK surgeons, they are very good FECO surgeons. And then the difficulty in these cases are that desma stripping is difficult. Then post-HSV endothelitis, I have a series of patients, both DSEK and DMEK. DMEK last month, it was published in Cornea Journal, 19 or 21 cases. And you see that while scoring, where it is more affected, DM is strictly adherent to that. You cannot remove it properly like other cases. So this microscope is very helpful. This is the Lumera microscope, though no financial. Again, that TECO, this is TECO after say, this might be 2015 video. And this patient I did same. Then this part is like your regular DSEK. And you see that patient on all this medication, oral steroids and oral antivirals, and this is the day 7 picture, horrible picture. And you see that probably it has stromal element has now come, So I keep on the same treatment, and you see that after 21 days, this is clearing, and you see that this is after 6 weeks, it is more clear. You see that after 3 months, it is much more clear, little bit of lipid keratopathy kind of pictures, and this is after 6 months, and the endothelial cell count is so good, and patient still continuing oral for 1.5 years. Similarly, this type of case, what will you do? This is the same kind of patient, multiple attacks of HSB in various form, and you see that the visibility is just like that. And again, one-eyed from Tripura to Kolkata. And I did DMEK in this case, just 1.5 years back, and you see that day 6, day 15, and this is 9 months. The patient is a farmer, back to the field. But if you do PK, you cannot do. Then next is the difficult one. Again, partly the visibility is the problem, partly the air management is the problem. So this is my teacher, ENT teacher. You have all read his book, Some of the Barin Rai Chaudhuri. So this is the picture. You see the huge bleb, but visibility is so poor, so poor. So I thought that I could do that bleb repair and scleral patch graft in the same time. That this is, you see that after 4 weeks post-op, graft clarity is 3+. This is after 2 weeks, after 2 years, you see that the vision is 20/40 and he is doing perfect. So there are some tips and challenges in this. If you see that, so you do all this. The section should be corneal. Normally we go sclerocorneal tunnel. DM stripping is like as before, but while you inject air, try to look the perilimbal conjunctiva. You see that the air bubble is going where? So you see that you cannot achieve optimum tamponade. So more bubble is coming in the peribulbar. The more you give air, it gives, the bubble comes in the subconscious space. And this patient, so what you do? You just keep the patient lying there for 45 minutes, 1 hour, because your tamponade is not that much. So it is not 60, this is late 20s or early 30s IOP. So you keep the patient like that. So these are the points to be remembered, the bleb condition. So first give trypan blue. You see the trypan blue is leakage in the bleb area or not. If it is not, you are fine. If it is coming, then you have to take all your things. How do you manage this? Air injection slow, very slowly, optimum tamponade. Then the same, even if you touch this area, that the problem will be there. So this area, air bubble is where you just hold with a forceps and air is leaking. So DSEK in post PK failed therapeutic, all has been discussed, but if you do the ASOCT, those are the posterior bump you see, and your graft size will be determined by those bumps. So you do all 4 quadrants ASOCT like 3, 9, 6, 12 position, and donor thickness thinner the better, and you take a smaller graft. So centering is sometimes difficult in post PK eyes. Then this is the easiest way to center it. You give stab because the posterior mismatch is there, many of the cases. So fluid drains. Also you can center it very nicely from the top of this. So your venting incision as well as centering you can do with this. So you do perfect centering. The same port you can use again and again. If you see that fluid is coming out through this thing. This picture you have shown, but I am showing the how difficult, the same case what Shoham was showing in the left-hand video. You see that what bleeding is can happen in the left-hand side. Mature cataract, and you see that while doing this synecholysis, the bleeding started. So normally the post-therapeutic, these are the problem. And you see that DMRexis, you always do it smaller. In post cases, you see that blood started coming. So in these cases, obviously the DMEK, blood is the killer for DMEK surgery. You cannot do DMEK. So I managed to do phaco, very soft cataract, so used to so in the bag, IOL, all this thing is there. But bleeding is going on. Bleeding is going on. We put like, you see the bleeding is coming during insertion of IOL. Then you put the graft, still bleeding is happening. So you put the graft in spite of bleeding is happening, because you cannot stop these multiple oozing points from the periphery. So you manage it, center it, and then give venting incision. So you secure all the ports. You give venting incision. You see what is coming. So interface, so much blood is there. You give venting, blood is coming. But this patient is this patient. So ultimately this patient do good. So another problem is RCM while doing therapeutic PK. Some of the optical PK also, you see there are two videos. One is very thick RCM in the right side, and left side this RCM is thinner. But you have to, sometimes you see the two layers are coming. One is thinner RCM, then you actually do the DMRexis. Probably you may not do the DMRexis in this case. So you just see this thick RCM versus thin RCM, then you do desmorexis, or you can go with the DSEK kind of thing. So these are the picture of this photograph. This particular lady, I remember, almost 8 years, one-eyed, very poor. But we did free for this, and she is doing so good. DSEK in shade, the Vanati has shown the beautiful photograph. Like this is, the difficulty is the DM stripping may not be perfect. What she was showing that it is fine, but you are not sure that you have removed. Then DMEK, forget DMEK. Because those are the, again, the DM attachment, and these are the child. So positioning of the child is another issue. So this is a, with shade, with Salzman nodular degeneration, I staged it because to see how the things are going. Then the corneal thickness was pretty high. I did this DSEK, but the clarity usually comes much, much later, maybe 6 months, or gradually it gets clean and clean and clean. DSEK in aphakia is a problem, especially if it is a large pupil. And I'll show this. This is the patient, you see that. That patient, again one-eyed. You see the age of the patient. So we can do DSEK, and we are recently doing air-assisted donor insertion. So these are the ideal cases. This surgery was done by Shoham. So I am showing this. You see that both anteriorly there is a lot, and in the DM there are some kind of epithelial RCM. What kind we do not know. Probably epithelial ingrowth. Long time aphakia done, 35 years. You see the pupil is halfway, it is not there. So we didn't use a single drop of Hilon in this particular case, except that to smear the wound. So this is air. This is a very nice technique for ACIOL, post-PK, and we are recently using this. So you just put it there, and in presence of AR, you put the thing in. yours should be cornea dome parallel. It goes so nicely, and you are manipulating from the stromal side. So air is remaining there. So we did not to unfold it, and we are doing many cases nowadays, this type of difficult cases, and this patient, perfect tamponade, then you do little venting. This is the end of surgery. We keep the patient for more time in these particular cases because we know that air is more important. And you see that post-operative, this is just 6-day post-op. 6-day post-op, you see the graft well attached, patient is 4/60. Happy, very happy patient, one-eyed, 85 years old, very happy. This is I had done about a year back. If you see the ASOCT picture, you see what is the pupil. Same method, the upper part, lot of corneal scarring is there, not edema. And patient lower part, that acts as a very good pupil, and patient is like 660 with +11, one-eyed, and they are doing fine. So DSEK test, this is very important. I have actually 3 cases, intraoperative conversion of DMEK to DSEK because of tests, for 2 reasons. One is bleeding. Second reason is you cannot strip the DM. In some of the, lot of DM folds, lot of scarring. So sometimes you need to take, again, reverse 26 gauge needle to cut, actually, that is not score, actually you have to cut it. Then you remove, you see some remnants, forget about it. And sometimes stuck with the fibrin membrane, it's like a fibrin glue, it doesn't open. So you forget about that DMEK graft and put a DSEK graft. So this patient I did 12 years back, I think, no, maybe more. 12 years back, again this patient, 2006 and 14 years back, this patient maintains with 1400 tecofold. It is not bad. My not all secondary failure is only few. Thank you very much. The extreme challenging cases, endothelial, better try for a DSEK. We welcome you to our new hospital. Will be coming next to Venu. Now we can take up question.
Yes. Thank you, sir.
So 14 minutes are there.
We have a lot of time, so any questions you can. Sir, are you still using venting incision?
In some of the cases. And some of the cases, venting incision is post-PK, yes. Post-PK, yes. Because sometimes it doesn't match the curvature. So post-PK, yes. Sometimes these aphakia cases, or you are not sure about your tamponade, post-VR surgery, aphakia, these are the cases, post-Trab, tube, these are the cases where we know that you see that whenever you give that air injection, last burst, the cornea gets little cloudy. When you do not see that cloudiness, your tamponade is not adequate. So you give venting incision, you see some fluid is coming out. So you give more air. And you wait for little more time. These are the no 10-minute business in this thing. So you wait for, because these, I always say, which one is more important? Rebubbling is important, or air going is behind is the important. So rebubbling is more important because these are the fragile patient, 85, only one chance you will get. So you give 30 minutes time, 45 minutes time. They can actually lie in the same, we take up those cases, maybe the last case of the day. So this positioning will be much easier. Hey, yes.
So there are 2 questions. What are your post-op regimen for antiviral? How long you continue and what is the
So antiviral, recently we published that, and all are PCR positive cases. So what I do nowadays is we see the PCR, it is PCR positive, then before operation, 7 days before operation or 10 days before operation, I do another PCR. So negative, then I do the surgery and I start antiviral 7 days prior to full course, either valcyclovir or acyclovir. And prednisolone if the patient doesn't have any contraindication to give prednisolone. 7 days before I start, and then operate on 7th day, same dose regimen for another 7 days. Steroid tapered off by 1 month time. But the antiviral continued, one patient is continued with because one-eyed, 2 years antiviral. So I have shifted to acyclovir to valacyclovir. Valacyclovir is same, it is a product for acyclovir. So the compliance is much better, once daily dose. Cost doesn't matter because it is only 50 rupees. Acyclovir 2 tablet costing 30 rupees. So it is fine for the patient.
And how do you manage the interface infection? Like one of the patient which was shown, or any of this fungal
Interface infection, DSEK versus DMEK, a lot of things happen. The DSEK you have already thicker lenticule downwards. So if it is a small pinhead type, you may take a chance. Mostly fungal, these are usually after 2 weeks, 3 weeks it comes. And mostly candida, these are these. And a lot of reports are there. So you give direct stab incision on the site. Wash it. Give amphovi. And also the other protocol for systemic antifungal, if it is near the periphery, so that, and topical. This I had one patient, and also Elma too has published one in Corneal journal, intra and intrastromal around that area. So it clears. But if it is a large one, so what will you do? You take the patient to OR, take out the lenticule, give intracameral injection of whatever, mainly amphotericin B. Wait for a few days, how the infection behaves. And you can do a regraft, re-DSEK after some times, maybe gap of 6 weeks to 12 weeks. So this is a normal protocol, and we had actually in our total hospital, maybe we have done around 3,000 DSEK, and we had actually, I can remember that 6 or 7 eyes we had interface infection. We can, one eye we had to, that we did everything that recurrence, we had to eviscerate, 3-4 grafts done. But most of the eyes could be salvaged, and we did at least 50% eye re-DSEK within 3 months. So these are the things.
So, and the last question regarding donor preparation, like how do you judge your initial entry? So you do a pachymetry pre-op, or you just go 2/3, 3, madam? Like what are your protocol for that?
No, the pachy, of course, whatever pachy we have on the donor cornea, eye bank cornea, it's not very exact.
Right.
So most of the time, like you assess in the slit lamp what you see accordingly. Generally, I always use 300 micron depth. The gauge this one for manual. With that I'll do. And for the automated one, generally I go for 400, or if it is really thick cornea, only 450. Around 400 micron head if you choose, generally you will. That's why I said we can do even a second pass, or after passing the thing, if you see it looks like thick, even in the automated one, I used to keep it on the microkeratome itself and do a manual dissection. Very thin pocket, and usually the interface is smooth only. Like you can do one more layer, you can take it off if you feel it is thick.
So what about?
So I have a different answer, a little different. So what tissue are you using? Are you using MK medium? Because we have 50-50. MK medium is 50 to 80 micron thicker than the cortisol preserved or Optisol GS. So number one factor is there. So if they can, my peripheral cut usually 400 or 450. Yes. So if it is a MK medium, I give 450. My intention, because in our scenario, we know the corneal thickness in our population is how much? It is almost 80% of the eyes, it is 510, 520. It doesn't much more. So my intention is, my grafts are always thinner graft because I go that way. Periphery, you are always 700, 750 like that. So you initiate at the limbus. So you go dome-wise, and your central thickness is 80 to 120 micron in my, I have done published also. It is the similar, but MK medium versus cortisol is definitely important. And second important point, ask your, because sometimes they forget to keep the thing in the ward temperature for 1 hour. So thawing is one of the important factor to determine the thickness, because it reduced by another 50 micron.
Okay.
So those are two important factors.
Thank you, sir.
Yes, Mamta.
Sir, can you give us a guideline regarding the sizing of graft, say for clean cases or for cases where we have failed optical PK? Suppose someone has already done a 7.5 mm PK in the initial case. So how one should go about it?
So clean cases, you just measure the overall diameter of all the things. Our cornea is smaller cornea in Bengal. We know that 9.5 to 10.5, that is all. So our direction is keep at least 1 millimeter working zone on the temporal and nasal side. So that way your graft size, with our average graft size is 7.75 or 8 max. But for DMEK this is better. DMEK average graft size is 8. For DSEK, because you have a thicker lemma, there is a chance of iris touch, all these things are happen. For PK, again you have to see the diameter, and posterior ridges are very important, host graft junction.
As in anterior segment OCT we have.
And those are very important. So normally therapeutic PK, it is very easy. So you have a plenty of space.
The
But
largest graft is there.
But if it is a 7.5 millimeter graft initially, then you need to take a call that which side, because, and your, that donor lenticule should be thinner. Your mentality will be that I will be go a little thinner DSEK in this particular case. So whatever if it crosses, because centering is difficult, crosses, so it is. If it is a thicker, then fluid seeps in through this and you have a detachment. And detachment rate is higher in post-PK cases.
Sir, in initial post-op phase, say for 1 week, if there is a localized edema, and in anterior segment OCT also we can see there is a localized detachment, how to, I mean,
That
do
is
we need
need
to
to
intervene in every case
With the DSEK.
with the DSEK? Yeah.
So the area, how much area? So normal thumb
if
rule
it
is
is-
that 1/3 versus more than 1/3. If it is less than 1/3, you can watch that patient with all that direction, what is the size of the ear, and try to manipulate that ear on that side. So positioning, head positioning, like right lateral, left lateral, whatever, even chin up, whatever. So that positioning is, if it is in the more than 1/3, then
Then
you
we
have
need
to rebubble it.
And superior versus inferior detachment, does this also make any difference?
Superior detachment though easier. So because air always remains there. So superior, you can watch more actually. Superior, and that day we had a junior surgeon. I said, okay, watch it. So after 1 week, he again see this patient, and usually it sticks.
Thank you so much, sir. Thank you, ma'am.
So such cases you use air only or the gases?
I never use gas. In my 3000, my series is almost 3000 EK series. So I never use gas, only 3 or 4 where re-detachment happening. So re-detachment. So one rebubble fail, then I take this patient for, and that time I ensure to do a PI, especially DMEK there is no matter, but PI for DSEK cases. So I do an external PI because internally the graft is detached, so you cannot do external PI, then wait, and then we do. Any question? So we have another 3 minutes time. Any question?
Hi, very nice lecture. I'm Tyler V from Hadassah, Jerusalem. And right now we are doing reverse transcriptase PCR for to check if the herpes is active. This is a much more accurate measurement to see if the cornea is in active infection. So before
somehow in our part we see lot of viral endotheliitis. So we have in my EK series is maybe now I crossed 70 patient with HSV endotheliitis, and these are the, and recurrence is there, of course recurrence is there. So in my DMEK series I published 19 patient, in there 3 recurrences happened. And sometimes recurrence in a virulent form. Virulent form. Initially it was HSV endotheliitis. Later on it is like all layer endotheliitis, all layer HSV keratitis. That is the point. So, but PCR is a guideline. You have a safeguard, you have a good feel that while you are doing the surgery, the patient is at least negative for PCR test. But if it is positive, wait. Give the patient antiviral. I have two patients with CMB, and you know the CMB is a costliest disease. So CMB, I did DMEK, and both the patients are doing fine, but the cost is more than 4 lakhs to them. Medicine got 18 months going on. Still I do not know when to stop.
Sir, even in CMB they say even topical ganciclovir.
But say that then the question is our ganciclovir topical versus their topical ganciclovir. This always bugged me that our ganciclovir probably does not work. That's why we are still stick to acyclovir ointment. But you cannot give 5 times daily.
And valsiclovir you use in 1 gram TDS?
Usually patient's body weight. So body weight determines 500 TDS or BD. It is fine. It is going fine.
Yeah.
Thank you.
Thank you. Okay, thank you very much.
Thank you very much. Very, very lovely discussion. So.